Thank you, Francesco, for that kind introduction. Carmelo and Fabio, also good friends, and it's always a pleasure to be back in Italy. My task today in the next 20 or 25 minutes is to discuss with you an evolving area in reflux management, which is the question of measuring pH, particularly of gaseous content as it rises up into the airways, and what implications it might have for the management of extraesophageal disorders. Here's an overview of what I'm going to cover. Typical and extraesophageal GERD. We're going to briefly look at the classification. We're going to discuss the effect of acid on the airways. We're going to look at fundamentals of pH testing. Then we're going to look at problems with measuring acid in the laryngopharynx. We're going to look at data on empirical therapy of extraesophageal disorders and why it doesn't work. And then we're going to look at new measures of measuring liquid and gaseous reflux, particularly as it applies to the laryngo-pharyngeal area. As Francisco said, both Fabio Pace and I were involved in the development of this definition and classification, which for today's purposes is only important for us to realize that while we diagnose reflux disease by symptoms in the vast majority of patients, there is a very large group of people with extraesophageal syndromes in whom the associations are first doubted. So there are patients with pharyngitis, sinusitis, fibrosis, and recurrent otitis media, where we really don't know if reflux is playing an important role or not. There are also established associations, such as with cough, laryngitis, asthma, and dental erosions, which I'm not going to discuss today, but where there's very good evidence that there's an association. These three in particular are important because they're managed by our colleagues in the ENT departments and in the pulmonary departments, and the diagnosis of patients who have reflux is particularly important, as I'll show you in the epidemiology in a few minutes. Here is a very large study looking at a large group of patients in Germany, 6,200 patients with established reflux disease, and we're now looking at the prevalence of these extraesophageal disorders in established reflux disease. Look at non-cardiac chest pain, chronic cough, laryngitis, and asthma, and you can see that in established reflux disease, these conditions are quite common, 13% reporting chronic cough of unexplained origin, which could well be related to reflux disease. If you look at the data another way, and look at patients presenting to pulmonary physicians with chronic cough and ask yourself, what is the final diagnosis in these patients? Once again, you find postnasal drip as the leading cause from chronic allergic sinusitis, asthma as the second cause, and reflux disease in 21% of patients is diagnosed as the cause of chronic cough. And if you look at the prevalence of the total, 1, 2, and 3 account for 86% of all patients with chronic cough presenting to ENT physicians after eliminating things like antihypertensive drugs and common obvious causes of chronic cough. Now, how can GERD cause pulmonary symptoms? And this is obvious to all of you, but it's important to reiterate that we may have aspiration or microaspiration of liquid content. But now, importantly, we're also beginning to consider the possibility of aspiration of clouds of acidic gas, where you have micronebulized acid in an acidic cloud which enters into the airways. We may also have reflex mechanisms via the vagus nerve by stimulation of the vagus nerve inside the esophagus with no mechanical component entering into the airways. And we can look at the data on both of these in the next few minutes. In recent years, there's been an extensive literature developed in the pulmonary literature about airway responses to toxic inhalants. The airway is densely innervated with somatic sensory nerves. And at low pH, there is a specific receptor called the TRP1 receptor, which we'll look at in just a minute, that is activated in the sensory neurons inside the airways and the upper airway passages. These nerve fibers connect through the trigeminal nerve and the vagus nerve to the brainstem, and you'll recall that through the vagus nerve we have a brainstem effect which affects the esophagus as well. As a result of these stimulations, there are a number of reflexes that develop. And the main purposes of these reflexes are to deter further inhalation of this toxic substance that's coming in, to expel the toxic substance by causing coughing and sneezing, or to dilute or neutralize this toxic acidic material entering the airways by producing more glandular secretion and by altering breathing patterns. So you can now imagine a scenario, at least hypothetically, where microscopic amounts of acid, either in liquid form or gaseous form, entering the airways can cause chronic coughing, can cause chronic production of secretions in the airways, and can cause a whole chronic pulmonary syndrome just because of constant reflux taking place through these normal channels that exist in the airways. So here's the proposed scheme. This was actually first studied in Italy, in Milan, and here is the proposed scheme that you may have this happen inside the esophagus, shown here in pink, where the receptors are stimulated by acid, work through the central nervous system, through the nucleus ambiguous, causing vasospasm and some of the reflexes that I already mentioned, including glandular secretion. A second mechanism is through the TRP1 receptor in the upper airways, where the receptor is directly stimulated by acid. The neurobiology of this has actually been very well worked out. There are 6 different receptors in the upper airways, and the one that we're most concerned with is the Vanilloid receptor, called the TRP1 Vanilloid receptor, which is sensitive to capsaicin, but also sensitive to heat and to hydrogen ions. And this receptor is exquisitely sensitive to changes in pH, and minute changes in pH will set off this pathway where the TRP1 receptor is stimulated, and then through a host of cytokines, you set off the chemical pathway that triggers the receptors in the brain. What experimental evidence do we have to support this? Here's a study from Milwaukee where we looked at this question of esophageal acidification on airway diameter. Now, this is an animal study. The black dark bars are the baseline airway diameter of the animal. After esophageal acidification, we measure the airway diameter again, and you see there's a significant reduction in the airway diameter in each of these animals. And after we neutralize the esophagus again, you can see that the airway diameter returns back to the baseline values, demonstrating section 1 of this pathway that I showed you, that by esophageal acidification, you can cause a reflux change in the diameter of the airways. If we look at another question, what happens when you introduce acid into the trachea of guinea pigs? This has been done also, and here we can see that a very minute amount, 20 microliters of acid, 0.1 normal hydrochloric acid, just as we have in the stomach, entering into the upper airways, causes a very marked increase in airway resistance. This is resistance measured on the vertical axis. And a control solution of saline has no real impact on this happening. In this particular specimen, introduction of a minute amount of acid into the esophagus of the guinea pigs did not have an effect, but this was likely related to the small volume that was being used in this particular trial. So we've seen now that acid can have an effect in the airways. Let's turn our attention now to how we measure acid. And I'd just like to remind you of the design of conventional pH catheters, because some of our problems with measuring pH lie in the design of these catheters. The catheter exists like this with a distal pH sensor, and at some distance from this sensor is what is called a reference electrode or a reference sensor. This is usually made of antimony, and this reference electrode is typically made of silver with a coating of silver chloride. And when a solution comes into contact with both of these, there's a potential difference between the two that's registered as a pH change on the electrode. Now, these distances have varied over time as technology has improved, and we'll come back to the gap between the sensing electrode and the reference electrode as being an important parameter later. With other devices where you have a proximal electrode, remember that the proximal pH sensor is separated from the reference sensor by a very long distance, which may be 20 or 25 centimeters, and that could become very important in measurement as we go forward. So let's talk then about traditional methods of diagnosing and managing laryngopharyngeal reflux. We can use pH impedance catheters, and you've heard a very elegant description of this today, and I'll show you one example of how it could be used. We could use standard pH probes positioned in the laryngopharynx. We could use the endoscopic findings at laryngoscopy. We could use questionnaires such as the reflux symptom index and the reflux finding score, and we could use empiric trials with PPIs. Now remember that this is the state of the art today. Our ENT colleagues and pulmonary colleagues are using one or more of these technologies. Most of them do not have access to pH impedance, so they either do this, or this, and we'll look at the results with each of these techniques and see as we go along. Now this is pH impedance. It's a slightly different device, but once again you see the graphic here. The pH sensor is located here. These are the impedance channels, and this is one of my patients who had refractory reflux symptoms. And what you can see when you look at the pH electrode here, you can see that there are very marked dips of the pH below the threshold of 4, shown by these filled-in periods where the pH is in the acidic range. You can also see that this patient is having episodes where the refluxate is rising high up into the esophagus. You can correspondingly see the sensors here, and each of these ones marked red here is an episode where the refluxate, the acidic refluxate, has reached very high up into the esophagus. Now this patient had extraesophageal symptoms. She has a chronic cough, and you could use pH impedance to surmise, in this case, that acid reflux may be the cause of the cough for 2 reasons. One, that there's a pathological acid reflux. Number 2, it's rising high up into the upper esophagus, suggesting it's getting very close to the larynx, and perhaps the 2 are linked. But then you will have cases like this. This is another patient with extraesophageal symptoms. Again, you look at the pH recording here. The pH recording is completely normal. There's no drop of the pH into the acidic zone at all, so this is a pH negative patient. But look at the impedance channel here. There is truly a lot of refluxate of weakly acidic or neutral material taking place high up into the esophagus. And these sorts of patients are a real challenge because we don't know whether their extraesophageal symptoms are truly related to this phenomenon or whether these are 2 discrete and unconnected events. You've seen a very nice study that that Radu showed you, which showed you that when you use these data and send patients to surgery, sometimes the results are really quite poor, only 10% in one of those studies. So in extraesophageal, we still have problems inferring that pH impedance studies are telling us exactly what's going on in the airways. What about just taking a standard pH probe and putting it in the laryngopharynx? This has been attempted many years ago, where you just took a shorter pH catheter and you put it into the pharynx. And here, pseudo-reflux was apparently seen by the drying out of the catheter, and 19% of all apparent reflux episodes with a conventional catheter placed in the pharynx were false positives, making this an unlikely method to give us a good result. Food and debris on the probe tip also cause a problem, and the probe can bury itself into the pharynx so that you don't actually get any pH measurement at all. Finally, in one study, looking at gaseous reflux, 564 out of 566 reflux events were mixed gas and liquid or gas reflux events, and the traditional pH probe placed in the pharynx was unable to measure these episodes at all. Now, our ENT colleagues like to look at the larynx and see a red larynx and tell us that there are these findings, and that means the patient has reflux disease. This is a problem now throughout the world, and there are 4 major findings described: vocal cord erythema, interarytenoid erythema, so here is the arytenoid, here is the little erythematous passage. Edema of the vocal cords is manifest by the gap here being somewhat closed. The interarytenoid bar, which is the space here between the 2 arytenoid folds, can be apparently thickened, and you can get this kind of cobblestoning in the back of the interarytenoid space, which has been another finding that's been reported as being diagnostic of reflux disease. When you actually put this to the test, the first study, which I'm not going to show you, where they showed this to multiple ENT physicians, resulted in a very poor correlation between what one person considered edema and what another person considered edema. So there's a problem already in the ENT physicians making the same diagnosis. But there's an even bigger problem when you take normal patients in asymptomatic people who have no problems and you look at their larynx. Here's what you find. Vocal fold erythema, 2 out of 105. 31 out of 105 patients had arytenoid edema. 75 out of 105 normal patients had the interarytenoid bar. And 22 out of 105 had cobblestoning. So what it's telling you is that, number one, the laryngoscopic findings that they use to diagnose reflux have poor reproducibility, and they're often present in normal subjects, meaning that these are not very good findings to base a diagnosis upon. The two questionnaires that are the favorites of American ENT physicians are the reflux finding score and the reflux symptom index. And these have been compared in 2 large studies to pH-metry, and they have been found to have very poor agreement both among the individuals administering the questionnaire and the laryngoscopic findings. In this large study published in the Journal of Voice last year, there was very poor agreement with both of these questionnaires. A recent study just published this month looked at 163 patients not on PPIs who had a Restech study now, which we'll look at in a few minutes. This is a laryngo-pharyngeal pH testing measure and had the questionnaire administered, and they used different thresholds for an abnormal Restech study or a laryngo-pharyngeal pH study, and the sensitivity, specificity, predictive values of the reflux questionnaire were only 50% at best in all of these estimates. So this suggests that so far we've now looked at endoscopic findings at laryngoscopy, we've looked at questionnaires that look for identifying reflux disease, and these are all systems that have many drawbacks and are not very good. Despite this, if you look at the guidelines of the American College of Chest Physicians, for example, they acknowledge that some of these measures are not very useful. So what do they say you should do for chronic cough? This is their guideline for chronic cough. They say you should eliminate upper airway cough syndrome, asthma, non-asthmatic eosinophilic bronchitis, which is an allergic disorder. And then they say you get to GERD and you should give the patient empiric treatment. So remember the number I showed you, 21% of patients have chronic cough. So a large number of people with cough are being given empiric therapy for reflux disease. Despite this, the medical literature quite clearly documents in the Cochrane database that there's no evidence that PPI therapy helps either infants or adults with chronic cough. So you can see the paradox between what is the science shows and what has actually been practiced. And indeed, we've looked at this in looking at all the studies in the literature. This is a meta-analysis that we performed with some colleagues in Bologna. And we looked at laryngeal symptoms and reflux, and we found there's absolutely no benefit for PPI therapy in this circumstance, regardless of whether you give it twice a day for 3 months at a time, and there's no difference compared to placebo. And similarly, if you look at asthma in a very nicely done trial published in the New England Journal, there was no benefit to treating with high doses twice daily of esomeprazole compared to placebo, suggesting again that in unselected patients, assigning them randomly to PPIs doesn't really help us. So how do we actually try to select patients, having looked at all of the methods we've used so far? So the newest technology that is being utilized or being studied in this area is a new probe, a very thin 1 millimeter sized probe that can be passed through the nose and is positioned above the vocal cords, where it can be left with a wireless sensor for 24 hours. The important aspects of the design of this probe are that the reference electrode located here and the sensing electrode are separated by a very, very tiny gap of 1/500th of an inch. So this gap is so small that the amount of liquid, gas, or other material that has to bridge this to create the potential difference is very small, and therefore it can measure aerosols or very minute amounts of acidic liquid or gas. So this is what it looks like when it's applied. This is the wireless device that sends information to a probe that the patient wears around the waist. And this is where it's located. This is the uvula. And the device has a little red light to help you position it as you pass it through the nose. And we typically just place it in the clinic, have the patient sit on the examining table and just put it in. It takes 5 minutes or less, and then have them go home. Let's look at some of the data on this particular device. Our first attempt at trying to examine what this device does was to ask the question, can it really measure the acidity of vapor? And there's only one way to do this, is to vaporize various substances and see whether it can actually measure accurately the vapor of these things. So here we have a temperature-controlled bath. We have 3 clamps here, and we have different solutions, and we have 3 devices or 3 different probes measured by somebody who is blinded to what we're doing on this side, who is looking at the wireless transmission and recording the data. So here's what we found. The first thing is that if we measure the pH of the liquid, or the standard of the liquid, using an electrode dipped into the solution, then we have a measure of what is the real truth. And here is that pH, the liquid pH of all these various solutions. Then we place them into a container in the water bath, and we use a simple nebulizer like the one we use in a fish tank to put bubbles in the fish tank, and we suspend the electrode above that in the air so that it is not touching the liquid, and it's several centimeters above, so it's only exposed to the fumes or nebulized substance. So here you can see the results of various substances, pH 7 buffer, and what is most important for us probably is 0.1 normal hydrochloric acid. And you can see that the probe measures fairly accurately the pH of the substances. Interestingly, those of you who drink regular Coke or Diet Coke, the pH of this is very, very acidic, and this is an important reason why some patients perhaps have acid belches after drinking soda. Because I knew we were going to be with Fabio and with Carmelo, we also studied several European drinks, and Fabio will be happy to see that Barbaresco and Prosecco are somewhat better than Diet Coke, and Pellegrino is perfectly safe, as you can see at pH 4.8, and as the gas goes away in these, it's also interesting that the pH gets better and better. And one of the problems we had with both Perrier and San Pellegrino was when you freshly open the bottle and dip the electrode in, this is the pH. But by the time we get the bottle into the nebulizer and we blow out the CO2, the solution becomes more and more neutral. This was an internal validity check, this pH change as well. So I think in the first set of experiments we established that one can actually measure the pH of vaporized substances where there's no liquid available. We're not doing anything else except bubbling stuff through it. Second question we asked ourselves was, what happens when you dry the catheter? Drying the catheter is a very important problem with laryngo-pharyngeal reflux, and the manufacturers told us that they built in some sort of electronic circuit that as soon as the probe dries, it records an artifact. So we tested that in a series of experiments, and I'm only going to show you one of these. In this, we dipped the probe into 0.1 normal hydrochloric acid, and here you can see it's recording a pH of 1, which is what we would expect. And then we placed it in the air. In this particular instance, we dried it with a fan, but we did it at room temperature. We did it at various things. And here you can see what is happening with the pH as time goes on. These are the time markers. And at about 10 minutes, you can see that the pH starts rising a little bit, and then abruptly it goes to 15, which is the inbuilt circuitry that the device has to record an artifact, that you get a pH of 15 on your recording. And since a pH of 15 is not possible, you know that these periods have to be excluded. So we were able to validate that drying out is not a problem with this catheter in terms of causing pseudo-reflux. This was repeated in multiple experiments, and it worked the same every time. So now we come to studies in human subjects. And a few studies have been done by others who preceded us in evaluating this device. And the first thing that became apparent was that our pH threshold of 4 that we use in the lower esophagus may not be valid in the upper airways. And here is a study where they looked at patients who had 3 devices placed. They had a pharyngeal probe, they had a Restech probe, and they had a distal esophageal pH probe with pH-metry. And you can see that as you rise up from the lower end of the esophagus and you look at acidic reflux episodes, the mean pH was 2.8, but in the pharynx it was 3.9, and in the Restech probe it was around 3.5. Similarly, if you look at weakly acidic reflux episodes, the pH tends to rise as you get higher and higher, and this is attributed to the secretion of saliva, which neutralizes some of the refluxate that comes up, perhaps also to the effects of motility and other unidentified factors. But the thresholds that have to be established up in this area have to be different from what we have in the lower esophagus. Our current situation is that our current normals, which we could argue about, have been established looking at a group of controls and getting the 95th percentile of time for two sets of pH values, upright at 5.6, so we use 5.5 as an approximation, and supine slightly lower, 4.8, so 5 is used as a threshold. A score has been developed called the Ryan score that takes the percentage of time, the number of episodes, and the longest reflux episodes, normalizes them to a normal cohort, and generates a score which can help a clinician to make an estimate of whether the patient has reflux or not. Now remember that all of these data can be considered to be quite small in number. The normative data are only in 55 patients, and we clearly need more information on this particular aspect. Let me show you some examples in our own laboratory of how we have been looking at simultaneous measurements using the Bravo wireless pH probe. This is a pH device that is implanted usually after endoscopy in the lower esophagus. It has two sensors which are placed 2 millimeters apart, the reference sensor and the sensing electrode. And remember that at the same time we have also this Restech probe resting in the pharynx. Here's an example of a very concordant study that we have. The green line represents the Restech probe. The purple line represents the Bravo pH probe in the esophagus. These are both done simultaneously, and the clocks on both of them are synchronized, so they're each measuring exactly at the same time. If we look at what the Bravo probe is like, this is how it's placed. You place the device on a little delivery system. You suction up an area of the mucosa. You attach the device here, and this is what it looks like. At the tip of it is a small electrode that's sticking out into the lumen of the esophagus that measures the pH, and this is its actual size. And it's sending data wirelessly to the little pager that the person is wearing on their waist. So here's another example of a patient with extraesophageal symptoms. This is the green is the Restech probe. The purple is the esophageal wireless pH probe. Now at first glance you may say there's a tremendous amount of reflux taking place in the esophagus, which is correct, and there's not a lot reaching up into the upper airways, except in this period, which is the nighttime period, where there's a considerable drop in the pH in the upper laryngopharynx. We could clearly explain this phenomenon by saying there are reflux episodes that don't reach high enough into the esophagus and therefore do not cause a pharyngeal problem all the time. So this is explainable. Both tests were positive based on their scores, and the patient had a very pronounced response to twice daily PPI therapy. Let's look at another example. Here again, the green is the Restech probe, the purple is the Bravo distal esophageal pH probe. There are two striking things about this particular study. There are reflux episodes that appear to correspond. So here's a distal esophageal reflux episode, and here is acidification in the upper airway shortly after that. But then there are a whole number of reflux episodes that are not reflected in the upper airways, perhaps because they didn't reach high enough. But then we have this puzzling phenomenon. We have here what appears to be a stable pH above 6 in the distal esophagus, but a very marked drop in the pH in the upper airways. And this particular phenomenon is something that we need to study more to understand, perhaps with impedance. But one possible hypothesis is that this could be an episode of acidic gas. Here we again see very marked drops in pH corresponding to acidification in the distal esophagus. And you can see while there isn't a point-for-point correlation, there is an approximate correlation with what is happening in the distal esophagus. This again was a patient with extraesophageal symptoms who had a very marked response to surgical therapy. This person had failed PPI therapy. Another example of simultaneous recordings, and here we can see in the nighttime period, and this becomes very important, I think. Here we can see the upper airway is shown in green. We can see multiple nighttime reflux episodes taking place here. And look what happens in the upper airways. There's almost continuous acidification of the airways with a pH of around 1 to 2 through this nocturnal period, where swallowing is reduced, where all of the protective reflexes are reduced. And perhaps this is one of the phenomena that might explain the chronic laryngeal symptoms that some of these people have due to prolonged acidification in the upper esophagus. So preliminary studies that have been done with the Restech probe, these are all small studies in very small numbers of patients, difficult to treat asthma in children. The LPR prevalence with the Restech probe was 56%. One study showed improved compliance with PPI therapy in patients who had a study that demonstrated reflux compared to just giving treatment empirically. High prevalence of LPR in adult asthmatic patients. One very interesting study in neonates was done to measure the acidity in the trachea using this particular device, but we don't really have any outcome data. One study has tried to correlate Restech findings with laryngo-pharyngeal findings, but again, as I told you, there's doubt about the laryngo-pharyngeal findings, so we really don't know what that means. So to summarize what I've covered, I've suggested that new approaches are required to manage extraesophageal symptoms of GERD. Why? Because our traditional methods of measurement have not been successful. Empirical therapy has not been effective in managing these patients. So we need to select the patients, and we need new technologies to help us. Reflux scales and old methods of measuring pH using traditional probes have significant limitations. We do need to study pH impedance a little more in this particular group. New devices like the Restech pH probe may be useful perhaps in clinical management, but we do need further outcome studies to actually determine whether the results of the Restech probe studies correspond with changes in clinical outcome, and that is the current gap in our knowledge in this particular area, which we hope to correct in the years to come. Thank you very much.
Thank you, Nimish.